We looked at CDC recommendations for HIV pre-exposure prophylaxis as well as CDC's recommendation for post-exposure prophylaxis. Now, given an HIV patient case, evaluate and manage common drug-drug interactions.
So when it comes to the pharmacokinetic boosters, we have cobicistat and ritonavir. Cobicistat is actually not an HIV drug, so it has no activity against HIV. Ritonavir itself is a HIV protease inhibitor. However, we actually don't use it for its protease inhibition because we use a lower dose. It's such a potent inhibitor of these enzymes that we actually use it at suboptimal doses. So the doses, 100 milligram of ritonavir is not enough to be active against HIV, but 100 milligram is such a potent inhibitor of these enzymes that we actually use it to boost the concentrations of other protease inhibitors. So you can see there are some differences between the two. One thing in particular about cobicistat is that it can actually artificially increase serum creatinine, and that's because it actually inhibits some of the secretion of serum creatinine. So it really does nothing to the GFR. So, obviously integrase strand transfer inhibitors are primarily the first line agents that we use for treatment of HIV. So currently we have 4 on the market: raltegravir, dolutegravir, elvitegravir, and bictegravir. Elvitegravir is the only one that needs to be taken with food. They're pretty much all taken daily. Up until recently, raltegravir had to be taken twice a day, but now there's a new higher dose of it that you can actually take once a day. In particular, elvitegravir and bictegravir are actually substrates of 3A4. So elvitegravir itself actually needs to be boosted. So cobicistat will inhibit CYP3A4. So as a result, you will need less of elvitegravir. So the pills will be smaller, and also with the half-life that's a little shorter, 13 hours, you can still dose elvitegravir once a day because of that pharmacokinetic booster. Now, bictegravir, although it is a substrate of 3A4, it does not need boosting. So, you need smaller doses of bictegravir, so 50 milligrams. So also the pill is smaller than elvitegravir. So that's another reason that boosting was not needed for bictegravir, because for 50 milligram the pill was small enough, whereas elvitegravir, even with a booster, you still need 150 milligrams. So if you didn't have that booster, you would probably need several times 150 milligram. So when it comes to drug interactions, elvitegravir will have the most, not because of elvitegravir itself, but because it has to come with cobicistat. So cobicistat will cause a lot of drug interactions, whereas the rest of them don't have a pharmacokinetic booster. One thing that bictegravir and dolutegravir have in common is that they both inhibit OCT2, and one thing that's important is metformin is actually a substrate of OCT2. So OCT2 is it's actually its function is to actually secrete metformin. So because they inhibit, you will see metformin levels increased. So that would be a significant drug interaction, because you will see a lot of diabetic patients on metformin. Bictegravir also inhibits MATE1. So let's look at some clinically significant drug interaction. So all integrase strand transfer inhibitors will interact with cations like antacids. So any polyvalent cation containing like aluminum or calcium, they will actually bind to integrase inhibitors and will prevent their absorption. So for that reason, anything that contains a polyvalent cation should be avoided, or actually should be spaced out by 2 hours. So 2 hours before or after you give integrase strand transfer inhibitors. So all 4 of them will interact with antacids, or not just antacids, anything that has. So if you were giving calcium pills, or anything that has a polyvalent cation. One thing that bictegravir and dolutegravir have in common is that they both will interact with metformin and dofetilide. So, so when it says avoid, when I say avoid, I actually mean contraindicated. So dofetilide is actually contraindicated with bictegravir and dolutegravir. Metformin is not a contraindication, so you just adjust the dose. Now, there's a really good chance that cobicistat may also interact with dofetilide. However, it's not in the package insert at the moment. So they may just not have studied it, but be careful with cobicistat and dofetilide. I didn't see it in the package insert, but I suspect cobicistat will also interact with dofetilide. Bictegravir is also contraindicated with rifampin because rifampin is a strong inducer of CYP3A4 and bictegravir is a substrate, so rifampin should be avoided. With elvitegravir, it's recommended to avoid anything that's a substrate of CYP3A4, like these statins are actually substrates of CYP3A4, and because cobicistat is a strong inhibitor, it's actually contraindicated to use these two. It is okay to use atorvastatin. The same goes with salmeterol. And then rifampin, of course, is a strong inducer of CYP3A4. That actually, because you actually need a pharmacokinetic booster for elvitegravir, so cobicistat is a strong inhibitor of CYP3A4, and rifampin is a strong inducer. So you should it's actually contraindicated to use rifampin because it will mess up elvitegravir levels. The same with some of the anticonvulsants like phenytoin. They're also inducers, so pretty much most inducers of CYP3A4 should not be used with elvitegravir because it needs help from a pharmacokinetic booster. And then, of course, because of cobicistat, patients use caution with hormonal contraceptives because cobicistat can inhibit and cause failure of hormonal contraceptives. When it comes to protease inhibitor, of course, these are the three most common protease inhibitors, and of course they're boosted. And the reason they can be boosted is because they're all substrates of 3A4, so they're not usually renally cleared. And for non-nukes, so efavirenz and rilpivirine are the two common ones that you use. Etravirenz actually for food you should take it after each meal. Food can actually increase etravirenz by 50%, so it's recommended to take it after meals. It doesn't necessarily mean empty stomach, but it just says take it after meals rather than with food. Now these are all CYP3A4 substrates. One thing that's special about efavirenz is that it's actually an inducer of CYP3A4. So you will also see a lot of drug interactions with efavirenz. So for protease inhibitors here and rilpivirine, here are some clinically significant drug interactions. So again, because protease inhibitors are boosted, you should avoid substrates of CYP3A4. So here are the three statins that are substrates of CYP3A4. Atorvastatin also has a separate mechanism of clearance, so it's not as strong. So it's only listed here for because it's in the package insert for itazanavir, boosted itazanavir, but it's okay to use atorvastatin with darunavir. There are also hepatitis C protease inhibitors that are also substrates of CYP3A4, so they should be avoided because these are boosted and the boosting will affect the levels of hep C drugs. And the same can be said about salmeterol. Now, itazanavir and rilpivirine both need an acidic environment for absorption. So with itazanavir and with rilpivirine, it's you should actually avoid proton pump inhibitors because they need the acidic environment. Now, here are some common drug interactions. So when it comes to drug interaction, typically most of the drug interaction will be with boosted protease inhibitors or boosted elvitegravir because of these, cobicistat and with protease inhibitors, they can be boosted either with cobicistat or with ritonavir. So that boosting will cause drug interaction. And then with the non-nukes, you primarily will see efavirenz interaction, but they're not as strong as those boosters because with the boosting you can actually have contraindications, whereas with efavirenz it's typically more of a caution, so you will monitor for drug interactions. So one thing that's important, especially with, well, actually, let me tell you. So when it comes to inhaled corticosteroids and beclomethasone is actually pretty green, so that meaning that there are no clinically significant interactions. So should you need, whether you have COPD or asthma patients, with HIV, beclomethasone will be your drug of choice if you need inhaled corticosteroid. This also applies to intranasal administration. But when it comes to fluticasone, please note that fluticasone is also available over the counter. So intranasal or Flonase, I should say. Flonase is the brand name. It's actually available over the counter. So note that boosted regimens are actually contraindicated. And so if a patient is on a boosted PI, they can actually walk to the pharmacy and grab Flonase. And so it's important to let them know that's contraindicated. Whereas triamcinolone is not really contraindicated. You just monitor for potential interactions. And so fluticasone and triamcinolone, these are basically for systemic administration, but fluticasone is also this contraindication also applies to intranasal, whereas triamcinolone intranasal doesn't have this interaction. Amlodipine and diltiazem are two drugs that you will commonly see. So there is interaction with boosted regimens and efavirenz. Not necessarily contraindication, but it's important to keep that in mind. So you will monitor patients' blood pressure and heart rate with diltiazem.
Okay, so we are here at the local Walmart. We're gonna go check out the pharmacy. You know where the pharmacy is? Okay. Okay, so I'm looking for over-the-counter allergy relief. Okay, so they have Flonase and Nasocort. Oh, Cecilia, you're here. I have a HIV patient who's taking boosted regimen. They want Flonase. What do you think?
No, that's a terrible idea. Flonase will interact with boosted regimen and non-nukes.
Oh, what should I do then?
Go this way. Nasocort.
Nasocort?
Yes.
Oh, thank you.
I'm here to help you.
When it comes to hormonal contraceptives, CYP3A4 has a role. So both efavirenz and ritonavir can affect the levels of progestins. So because of that, it is recommended to use additional contraceptive methods when the patient is actually taking efavirenz or boosted regimens. So with these, they're not really contraindications, but it's important to let the patient know that these can make hormonal contraceptives ineffective or less effective. So they should use alternative methods of contraception. So primarily with boosted and efavirenz. So as I mentioned before with statins, basically the three statins that go through CYP3A4 are listed here, but atorvastatin in particular doesn't primarily depend on 3A4. So, historically, atorvastatin was considered a drug interaction with anything that affected 3A4, but nowadays we have data that atorvastatin is not as much affected. So, the only exception is that with atazanavir, atorvastatin is actually contraindicated. But with with darunavir, for example, they just recommend the maximum dose. But it's okay to use atorvastatin with darunavir. So these two contraindicated with anything that has cobicistat or ritonavir. So anything that's boosted.